The focus of this video is on the nursing implications of administering anti-epileptic drugs to people. And of course, our primary concern is doing it safely and making sure that the drugs have their intended effect. So there's always assessment data that we want to bear in mind. What's their health history? Of course, what are their drug allergies? Because if they have an allergy to any one of these medications, we're not going to give them. And being aware of their basic liver function studies. A handful of these drugs are known to have some negative effect on bone marrow and uh, generation of blood cells, and so we're going to want to know their baseline complete blood count as we're monitoring the effectiveness of the medication for them. So if I show you the table 14-1 of anti-epileptic drugs, you will see that the vast majority of them are given orally. Just a handful are also given parenterally. And phosphonetuin, which is the prodrug for phenytoin or Dilantin, is given only parenterally. The rest of them, though, are typically given orally. And so when our patients are taking oral anti-epileptic drugs, they need to take them, they need to be quite faithful about taking them at the same time or pretty much the same time every day. Very often, because so many of these will cause an upset stomach or some GI distress, it's wise to take them with meals, and people are less likely to have an upset stomach. Some of these oral preparations come in extended release form, so obviously we're not going to chew them, crush them, or anything, because that's going to change the way the drug is released. And if a patient is made NPO for whatever reason prior to surgery, or because they have some GI problem that means that they can't take medications, because these drugs need to be taken regularly and at pretty much the same time every day, it's best to go ahead and consult with the neurologist, the prescriber, the person who's managing their anti-epileptic drug therapy, to see how long can they hold the medication, can a parenteral form be given if it's available, and what dosage, and so on. Many of the, I shouldn't say many, but a few of these anti-epileptic drugs do come in IV forms. And so under those circumstances, we are going to follow the instructions as to whether the drug is given diluted in additional IV fluids. If it can be given without being diluted, usually these drugs are given slowly intravenously so as not to enter the vascular system too quickly. We're going to monitor patients' vital signs, and especially with phenytoin, because it can cause the purple glove syndrome. Be very careful that you're administering it through a patent IV catheter, and that the drug is not leaking or extravasating into the surrounding tissue, And IV phenytoin is not compatible with 5% dextrose or lactated ringers or some of the other crystalloid IV solutions. This is a drug that you will only use with normal saline. There are a handful of drugs that fall into that category. So we need to know that what's compatible, what the drug is compatible with which IV solutions. Patients, people with chronic illnesses often do well to journal their symptoms, and people with a seizure disorder are no different. In other words, can they journal or keep track of their seizures? And they're going to want to communicate with their neurologist and let the neurologist know, are they having seizures despite being on the medications? Are they on monotherapy? Is the monotherapy not working very well? Does another drug need to be added? They're also going to monitor their adverse effects to make sure that they are achieving a balance between minimal seizures to no seizures and minimal to no uncomfortable adverse drug effects. People with epilepsy are also very wise to wear a medical alert tag or identification of some kind that's always on them that indicates that they have a seizure disorder or epilepsy. If they suddenly have a seizure, become unconscious, and the emergency medical team is called, and there's no information for the EMS staff to look at, then the first responders are going to be missing some really important information about this person's history. I mentioned that many states, most states, I think, have driving restrictions for people with seizure disorders that are not well controlled. Many of the restrictions are lifted after the person has been seizure free for a certain period of time. And because those rules and regs vary from state to state, it's important that the nurse know the rules and regs for the state that he or she is working in. And for many patients, maybe even most patients, the anti-epileptic drug therapy is lifelong and or long term at least. It's not a cure. These drugs do not cure epilepsy. They help to manage the seizures, and people are probably going to be long term and possibly even lifelong. This is important for them to know. As I mentioned, we're monitoring for both therapeutic effects and adverse effects, especially central nervous system effects, the GI effects. The hydantoins like phenytoin can affect the bone marrow and have abnormal blood cell values, and there are a couple or a handful that are toxic to the liver. So these have to be monitored very closely. Patients need to go back to the clinic, especially if they're receiving an anti-epileptic drug that has a narrow therapeutic index, in order to monitor their blood levels and monitor the effectiveness of the therapy.